Hello friends, today's talk is on important skill which should be learned by all paramedic, EMS, nursing staff, consultant, doctors and even in the community about the important skill of helping a patient or a victim who has underwent a cardiac arrest or a respiratory arrest. That is the science of cardiopulmonary resuscitation. Now, as far as the evidence goes, the American Heart Association guidelines, which is updated every 5 years, is the best evidence based practice in this regard. So, today my learning objective will be to acquaint you all to understand the steps of chain of survival, to get you the cognitive information regarding the basic life support guidelines 2020, why it is important to perform a high quality cardiopulmonary resuscitation, and ultimately it's a science to improve the life and saving lives. Understand the appropriate use of automated external defibrillators. Then also I will cover in the later part of the section regarding in hospital cardiac arrest, what are the latest advanced cardiac life support guidelines and algorithm. And you must understand that cardiac arrest situation is a situation where multiple interventions are required, and early initiation and meticulous intervention requires a teamwork. So the team dynamic is very important for successful outcome of the CPR or getting a return of spontaneous circulation with patient with intact neurological function. And at the same time, after return of spontaneous circulation, a skilled critical care team led by the intensivist is very important for this important period of post cardiac arrest care to bring back the patient to its normal state. So first let's understand this important chain of survival. The integration of various components is very important to save life. So first and foremost is the early recognition and prevention is the first component. More delay the patient develops outside the hospital, more time delay will decrease the chances of survival from the cardiac arrest. Immediate activation of emergency response system. Nowadays we have this number of, in the Maharashtra, at least 108, which you can call and activate the emergency response system. Once you have diagnosed a patient, you have witnessed a patient with cardiac arrest, scene is safe, you go ahead with the cardiac compression, the manual compression of the heart. If the device is available, the automated external defibrillator use should be done, so it improves the chances of survival. And then shifting the patient to post cardiac arrest care once patient develop the return of spontaneous circulation, and with a good post-operative post cardiac arrest care leading to the recovery of this patient. So the chain of survival is no different in hospital or out of hospital, but the time is essence, and the early initiation of cardiac compression is a very important step. So to understand this basic life support, this is the steps which we should remember. One is the first is the scene safety. In COVID also we have seen that first do no harm, at the same time you have to save yourself. So use of substance isolation precautions when you are dealing with such patients, and of course the safety of the scene where you are going to perform, where the victim might have fallen anywhere and you have to move him to the safe place or keep him on the firm surface, ensure that the scene is safe, see that he is not having any breathing or is in cardiac arrest, you have to call for help, activate the emergency response system, immediately start manual cardiac compression, get an AED, that is automated external defibrillator. As I said, the early use of AED with when the rhythm is still shockable, the chances of survival are better. And then this integrated approach is done. Once the team comes, you hand over for the advanced life support team. So how do you recognize a cardiac arrest? So if there is a lay person, he can easily recognize by patient is unconscious. You tap on the shoulders, that he's not arousable. You see that he's not breathing or the breathing almost gasping. So you should consider him as a cardiac arrest. For the lay person, he can start immediately the compressions. For healthcare provider, there is an additional step. He can see the central pulse, that is a carotid pulse, by putting the fingers not more than 10 seconds. He should not delay the initiation of cardiac arrest. So check for pulse. If it is absent within 10 seconds, either carotid or femoral, these are the central pulse, carotid is advisable, and then you start the cardiac compression. The patient should be lying on the firm surface with like shown in the figure. You keep heel of your one hand on the midpoint of the sternum, the other hand crossing the first hand. Don't bend the elbow, and use your body weight to give compression at the depth at least 1.5 to 2 inch. So what you are doing is compressing the heart between the sternum and the vertebral column. So you are creating systole and diastole manually, and the rate of compression should be 100 and 120, at least 100 per minute. That is recommended for perfusion to the brain. And the ratio of ventilation compression, so compression is 30 compression and then 2 ventilation, 2 breaths has to be given through the mouth to mouth or mouth to nose, or using the device mouth to mask. C for the adequate chest recoil. In case of layperson cardiac CPR, the you can continuous cardiac compression is also acceptable. In order to improve the quality, you have to push hard and fast, and at the same time do not hyperventilate. So if you give the breath, it should be just to get the chest rise, and if you hyperventilate, there are chances of gastric regurgitation and vomiting. So the simple step of CAB, so the new guideline says compression, then airway, and then breathing. So that is the update thing they have done, and more importance is given to high quality of cardiac compression. Once, as I said, the public access device, so there is available, automated external defibrillator is available, or in the vicinity, like as a public access device in some malls or airports, you must have seen that. So it's a simple device where the instructions are given on the pamphlet there, as shown in the figure here. There first you plug on the AD machine, attach the paddles. These are the paddles with sticky adhesive paddles, one on the right side of the chest and one on the left side below the uh, around apex beat. And then in children, you can less than 8 years, it can be in front or on the back. Check for the rhythm. So during rhythm analysis, you have to stop the CPR, and the machine will analyze the rhythm, and it will be self prompt to give the shock. Once shock is advised, you press the shock button. Before that, clear all the people, nobody touching the patient victim, and then you start immediately resume CPR after giving shock. So this increases the chances of return of spontaneous circulation. So early use of automated external defibrillator, the name itself says it's automated with voice prompt, so you don't have to the the rhythm will be analyzed by the machine. So one important component that they have described in this new guideline is uninterrupted cardiac compression. So your heart is getting compressed between the sternum and the vertebral column. So you are creating the systole and diastole, and you can see the coronary perfusion pressure here. The moment you stop the compression for breaths, it goes down and again start rising like this. So they say that your cardiac compression fraction, the time you compress the heart, you achieve this peak, should be around more than 80%. So that can be achieved by uninterrupted cardiac compression and minimal interruption only to give two breaths. Sometimes you can use feedback device if available, like end-tidal CO2 monitor if it is available, or intra-arterial BP in intra-hospital cardiac arrest can give you clue regarding adequacy of cardiac compression depth. Now, because of this reason of uninterrupted cardiac compressions manually to machine, there was a trial of Lucas machine, that is Lind's trial. This machine has got a pump. You can put it on the chest of the patient and set the rate as 30 is to 2 and 110 per minute. So the machine will be giving, but there is problem with the device malfunction, device lodgement, sometimes inadvertent wrong placement and injury to the ribs. So this is not routinely recommended, does not show to improve the outcome. So what is the updated guidelines of BLS algorithm 2020? First is the verify the scene safety, of course. Check for the responsiveness. Once the patient unresponsive, call for help. Get an emergency response system 108, or ask them to get an AED if somebody can get the emergency equipment. So automated external defibrillator. Then look for breathing. If the patient is breathing, sometimes the pulse is absent but he is breathing. So pulse is felt, he is not breathing. Then you give rescue breath, every one breath every 6 seconds, and check for pulse every 2 minutes. If there is absent breathing and absent pulse, monitor the patient and start the cardiac compressions. That is, no breathing, only gasping, pulse not felt, 30 compressions and 2 ventilations. Once the AED arrives, as I described earlier, it will check the rhythm. If it is shockable, give the shock and resume CPR until the victim starts to move or the advanced life support team takes over. If it is not shockable and the voice prompt of AED is no shock advised, you can go ahead with the continue with the quality cardiac compression. So this is all about basic life support, which doesn't require any instruments, doesn't require any advanced monitoring system. It just require a cognitive and the motor skills and early recognition, immediate cardiac compression, then the airway, and then the breathing. So CAB and getting an AED, and this is the algorithm which healthcare providers should follow and make your staff learn this important skill. Now coming to advanced cardiac life support. So what is advanced cardiac life support? The most important is that basic life support is the foundation. So before you start the ACLS patient who has received the high quality CPR, basic life support, you start with oxygen and it improves the chances of survival. Then you attach the monitor to the patient. The monitor will tell you about the rhythm which you have to identify. Unlike AED, you can see the rhythm here and you can identify rhythm to find out whether it is shockable rhythm or non-shockable rhythm. So the shockable rhythm for cardiac arrest, the ventricular fibrillation and pulseless broad complex ventricular tachycardia. You can use the manual defibrillator here and the IV drugs, which are the two drugs which are normally advised. One is epinephrine The atropine has been taken out, and amiodarone in case of ventricular fibrillation, ventricular tachycardia. In non-shockable, you have to continue the cardiac compression. Again, the role of epinephrine early, and the second rhythm is pulseless electrical activity, which is not shockable. So let's see this one by one. So while we are doing the CPR, always our goal should be to correct the underlying cause. So in advanced cardiac life support, you're continuing the CPR, you're continuing manual activity, but try to correct the underlying cause, like whether it's hypoxia, whether it's hypovolemia. These are the two common H you think of. If there is a trauma, think of tension pneumothorax or tamponade, because until that is reverted, your manual compression may not help. So this is the causes of HNTs, which has been described further, will be discussed. So first is identification of rhythm. Now you see these two rhythms here. So these are the cardiac arrest rhythm. So if you get a broad complex tachycardia regular, as you see in the top figure, it's a ventricular tachycardia and pulse is absent. It's a cardiac arrest rhythm which you have to shock immediately or defibrillation. The second rhythm here, you see a chaotic rhythm without unorganized and a fibrillatory wave, that is a ventricular fibrillation. And so again, early shock will help in survival of this patient. So this is the latest algorithm which has come up with AHA with once you have identified, you have to shock the patient. Defibrillation is given as the placement of the pedals in the similar place, right infraclavicular and left apical area, and defibrillation 120 to 200 joules of shock. If it is biphasic, then you give a shock before you are charging the patient. Till that time you can continue the uninterrupted CPR. Once it is charged and you are actually shocking, you have to take the precaution of clearing the victim. Everybody should be away, and once you have delivered the shock, again the CPR is resumed. The important point here is that the role of epinephrine comes much later. So if the patient is cardiac arrest with shockable rhythm, the role of epinephrine is after 2 minutes. After 2 minutes of after the second shock, if it is not reverted, then you give epinephrine 1 milligram 3 to 5 minutes. Every 3 to 5 minutes you can repeat, and you can consider the advanced airway. So you see a lot of teamwork is required here. So one person is defibrillating, one person should be managing the airway, one person should be giving the cardiopulmonary resuscitation, sister should be giving the drug at the right time, and after third shock there is a role of amiodarone or lidocaine. So this whole is a teamwork, and a good teamwork will improve the outcome of this patient. Simultaneously you have to think of HNTs, correct the reversible causes, and once there is return of spontaneous circulation identified like by pulse and blood pressure, or victim starts to move, there will be abrupt increase in the PO2. These are the endpoints of resuscitation, immediate endpoints. On the other side of algorithm, if the patient has something organized rhythm but there is no pulse, so this is a situation of pulseless electrical activity. There is the electrical activity but there is no perfusion, or there is a straight line. Sometimes the monitor may get disconnected while you're doing CPR. So always check for the lead placement, always check for the gain, and confirm an asystole. That is a flat line protocol. You continue with the CPR, and in this algorithm again you continue with epinephrine 1 milligram every 3 to 5 minutes. There is no role of intracardiac adrenaline, it is IV. There is no role of atropine. Earlier it was, it has been wiped out of the new guidelines. So it's made simpler. So you start the CPR, give epinephrine every 3 to 5 minutes, continue compression, consider advanced airway, think of hypoxia, hypovolemia, tension pneumothorax, and look for the signs of return of spontaneous circulations. So what are these HNTs we are talking about? This is The correctable causes, as I said, hypovolemia, hypoxia, hydrogen ion, hypo or hyperkalemia, hypothermia, thrombosis, pulmonary embolism, coronary thrombosis, tamponade, toxins, tension pneumothorax. These are there is a element of intra-hospital cardiac arrest. There is a role of point of care ultrasound which can might help, but it should not interrupt with the resuscitation and can be used to identify these conditions. Similarly, arterial blood gas, if the patient has arterial line, may help to find out these electrolyte abnormalities which can be corrected. Coming to the team dynamics, as I was saying, the CPR, advanced cardiac left support, is a teamwork. So these are the various team members standing around the victim. Here is the airway person with the defibrillator. The team leader sees that everything is getting clearly, is getting the good CPR, is following the algorithm, is managing. One person is recording for the any medical legal and any missing element in the resuscitation and for the later debriefing. So it is a teamwork, and therefore the team dynamics are very important. One should know one's limitation. There should be closed loop communication. If the leader is asking to give adrenaline, the dose, the sister should call back whether she has given or not. So every recorder is keeping that every 3 to 5 minutes being given. There has to be clear messages. It's a high emotional situation state, but then the resuscitation is should be done in a meticulous manner for better survival. There is clear roles and responsibilities. So person who is doing, suppose defibrillator, he should concentrate that nobody gets hurt while he is giving shock to the patient. He clears everyone. Similarly, the uninterrupted cardiac compression has to continue. If the one is fatigued, he should switch over with the airway person. The airway persons should be very good in handling airway. If one knows the limitation, he should not do the thing which he is not aware about. Suppose you have a anesthetist in the team, he is a better person for airway than rather than keeping him for defibrillation. Knowledge sharing is important. If somebody is come up with the idea of whether this renal failure patient hyperkalemia could be the cause or hypovolemia, so there has to be knowledge sharing while the resuscitation is going on. Constructive intervention, if the leader is sometimes maybe about to make a mistake, or a colleague is about to make a mistake, like giving a shock to the non-shockable rhythm, so there has to be a constructive intervention by the team members and avoid such uh, mistakes. And in the end, of course, a re-evaluation summarizing of the after return of spontaneous circulation. So this is a effective team dynamics which helps in this resuscitation survival rate, and this can be practiced on the mannequins so that in a real life situation uh, there is no mistake. Once the return of spontaneous circulations happen, uh, you should check the blood pressure, maintain the ventilation, put an endotracheal tube if not already put, look for the oxygenation, treat the hypotension with saline or inotropic agent. Then the role of therapeutic, target temperature monitoring I will discuss. Then if what is the cause of cardiac arrest, whether the coronary perfusion will help, and what are the advanced critical care to be done. So about post-arrest algorithm, as I said, they do not hyperventilate. So breathing rate should be 10 breaths per minute. You can monitor with normocapnia that carbon dioxide should be 35 to 45, and saturation should be around 98 to 92 to 98%. Systolic blood pressure or mean arterial pressure, if you're targeting, should be more than 65. Get an 12 lead ECG. So these are the things you do in initial stabilization phase. Once you get the ECG and showing STEMI, so that is the cause of cardiac arrest or unstable cardiogenic shock, then the patient may have to be moved to the cath lab for intervention. If the patient follows command, that means the neurological system is intact, he may not require the target temperature management. Other critical care management is important. But suppose if he is not obeying his comatose to maintain the stable metabolic rate of oxygen consumption and prevent keep the brain safe, you may have to avoid fever and keep target temperature managed 30 to 36 degrees centigrade. EEG monitoring may be required, and other critical care management will be required. This is a high risk situation. Now, relatives will be asking about the prognostication. You have got the return of spontaneous circulation, but it's a half battle one. Now, you have to prognosticate clinical imaging, EEG, lactate clearance, and biomarkers. These are the various modalities for prognostication. There's timing for prognostication is very important. So, TTM or target temperature management should start as soon as possible. Within 24 hours, the patient is not responding. The imaging has to be done if patient is stable within 24 hours. CT will show the gray matter, white matter changes and loss of differentiation about the any hypoxic injury the patient has developed, or prognosticating a patient if you want to do MRI after 24 hours. Electrophysiologically, if it is available, somatosensory, evoke potential N20. Clinical examination is very important. The evidence of myoclonic jerk will say that patient prognosis. Then pupillary light reflex, corneal reflex. These are the bedside tests which can be done. Serum biomarkers like neuron specific analysis are not available, but in most of the centers. So pupillary light reflex is 72 hours or more. If it is absent, then the chances of outcome are poor. If the patient has persistent myoclonus or dysglycemia or lactate clearance poor, these are the signs of poor prognosis, and accordingly you have to tell the family about the prognosis. In presence of but this should be no derangement or neuromuscular blocking agent should not be there while you are evaluating this. So time to prognosticate is around 72 hours. Like MRI, I have talked about. EEG at 72 hours and 20 potential at 24 to 70. So they are time sensitive, and multiple modality approach is important with along with clinical examination. There should not be any residual effect of hypothermia medication, and no single test actually can predict neurological recovery with 100% certainty. What are the ethical consideration? The termination of resuscitation effort. So when should I terminate? If there is a local protocol in the hospital that can be used, or the patient has a valid, do not aggressively resuscitate, do not resuscitate. This is a very legal, medical legal condition, whether I have to continue CPR for 10 minutes, 20 minutes, 40 minutes, 1 hour. So the parameters or variable which should be looked at is the initial rhythm. If the initial rhythm is asystole, the outcome will be poor. Age of the patient more than 60 with multiple comorbidities, malignancy and other things, and stage diseases, you should think. No flow time is more, the patient came to the hospital late. CPR duration, more the duration, less the chances. So it has to be the individualized decision depending upon the clinical situation and the reversibility of the condition. AHA recommends that BLS can be terminated if there is no return of spontaneous circulation before transport, or no AD shock was delivered before transport. This is for out of hospital cardiac arrest. And arrest which is not witnessed, no bystander CPR, so no return of spontaneous circulation before transport, no shock was delivered. All this we can wait, and there is no point in resuscitation further. So these are the guidelines which can be tailor-made as per your local guideline, and I hope I gave the at least the cognitive part of new guidelines, and motor skills has to be developed on the mannequin, so that real life situations, such type of training should be attended which are taken by American Heart Association. Thank you very much.